Hello everybody and welcome to today's webinar hosted by VitaFlow. My name is Lucy Evans and I work as a Global Marketing Manager at VitaFlow International Limited. I'm also a dietitian by background. Today's webinar is titled An Introductory Session Regarding the Use of a Low Potassium Feed as Part of the Dietary Management of Paediatric Kidney Disease and will be presented by Fiona Graham, Lead Paediatric Renal Dietitian for Scotland in the UK. So before we get started, let me run through a few housekeeping items. This webinar is intended for healthcare professionals only. The webinar will last approximately 60 minutes and will include time for questions at the end. If you would like to ask a question, please use the question feature on your GoToWebinar toolbar as demonstrated here. All questions will be screened and a select number will be answered by the speaker at the end of the presentation. Please note that this webinar is being recorded and will be available on VitaFlow's website for healthcare professionals called VIA in approximately 3 to 4 weeks. You can access a certificate of attendance and a self-reflection tool in the handout section of the toolbar. Here you will see a set of disclaimers. The material herein is accurate as of the date presented and is for educational purposes only and not intended as a substitute for medical advice. The views herein are of the presenter and do not necessarily represent VitaFlow's views. The learning outcomes for today's session are listed here. They are to understand when and how to use a low potassium feed as part of the dietary management of paediatric kidney disease, to be aware of the key considerations to take into account if using a low potassium feed, and consolidation of this learning will be presented through discussion of a case study example. So let's get started with the webinar. VitaFlow is delighted to introduce our speaker Fiona Graham for today's presentation. Following graduation with a dietetics honours degree in 2010 from Queen Margaret University in Edinburgh, UK, Fiona worked in adult dietetics for 1 year before specialising as a paediatric dietitian. For the last 10 years, between the Royal Manchester Children's Hospital and the Royal Hospital for Children in Glasgow, Fiona has worked in various specialities within paediatrics, including neurology, long-term ventilation, feeding clinics, allergies, burns and gastroenterology. Fiona has been the lead renal paediatric dietitian in Scotland for over 5 years now and is the current chair of the Paediatric Interest Renal Nutrition Group, or PRING, which are a group of paediatric renal dietitians from the UK and Ireland. VitaFlow would like to thank Fiona for taking the time to present for us today. I'm about to hand over control to Fiona now to present, so please be aware there may be a short delay in handing over controls. So over to you, Fiona.
Good afternoon from Scotland, everybody. I hope you can hear me all. I will try and move the slide along just now so we can get started. There we go. So today I've been asked to speak to you about the introduction of a low potassium feed as part of the dietary management of paediatric kidney disease. Now, initially we had talked about this being a low electrolyte feed discussion, but one thing to bear in mind, and the reason we changed it to low potassium feed, is that the low potassium feeds that we're talking about are low in calcium, phosphate, potassium, but they are higher in sodium than standard formula, so it's not exclusively a low electrolyte feed. We've changed the wording to replicate that. So what I hope that we'll cover today is understanding when and how to use a low potassium feed as part of the dietary management of paediatric kidney disease. I want to show awareness of key considerations that we would take into account if using a low potassium feed as part of our dietary management of paediatric kidney disease. And I hope that this will have practical application at the end, where we'll consolidate this learning through a discussion of a case study example. Next slide, please. So our key considerations when this is not a static picture need to be that any change that we make, we need to find out what happens after. So once we've made a change, always adjust and monitor We would be looking at growth, especially in our population group as children, because that is fundamentally important. So looking at their weight, their height, their head circumference, and tracking this to look for trends. We would be looking at their biochemistry, including their potassium, their phosphate, bicarbonate, creatinine, and urea, and other elements that we will go through in this talk. And we always want to know what is happening with the clinical picture. So is the kidney function changing? Are there medical interventions happening that would influence our dietetic decisions? I've put the next part in red as it is very important that when we are changing to a low potassium feed, or we're changing in part to low potassium feed, we're decreasing the amount of potassium that the body is given, there is always a risk of potassium becoming low if the function does change. So please bear this in mind. We need to monitor the potassium levels. This is essential. From a very practical point of view, because when we change feeds, it can be multiple calculations at one time, then we need to look at documenting the feed breakdown so it's much easier to change and compare. So from a very practical point of view, to save yourselves time, because there'll be so many tweaks and alterations that can be made, I would always write down with the recipe that you've made per 100 mils how many calories, how much protein, how much potassium, and how much phosphate it's giving you, so that it's much easier if you're looking in the future or looking to go back a few steps to the previous recipes. So looking at when we would use a low potassium feed. Now, essentially, what we are doing is looking at the information the kidney is giving us, and it's telling us that it's not working to get rid of the potassium that it's currently being given, so we need to decrease the amount that we put into the body. And this would be to prevent the potassium going high and hyperkalemic, which can then cause cardiac changes and medical intervention, which is what we're trying to avoid. So with a high potassium, so hyperkalemia, or potassium rising with an irreversible cause, this is when we need to get in with a low potassium formula. It can be for multiple reasons. The kidney could not be working as well because it's had an acute kidney injury and the urine output could be very poor. They could be hyperkalemic, they could be anuric. With chronic kidney disease, with declining kidney disease, normally we'd be looking at low potassium or lowering the potassium given to the body towards the end stages of kidney disease. But one of the things to bear in mind is that the medicines that we use in chronic kidney disease and in acute kidney injury can also cause the potassium to rise. So it's worth taking these, being mindful of these things. So all of our ACE inhibitors like captopril and enalapril, which are very good at managing blood pressure, can also have the effect of increasing the potassium levels. All our angiotensin receptor blockers, our ARBs like candesartan, that has the potential to push up the potassium as well. Tacrolimus also, as immunosuppression in our transplant patients, could increase the potassium levels. And always remember, which we don't probably see a huge amount in the paediatric population, but if a potassium sparing diuretic like spironolactone is used instead of, say, furosemide, then this could be a reason why the potassium is increasing. So it's always important to communicate with your pharmacist, with your medical staff, to look for the reasons for rising potassium. The other thing to mention is, and it's always worth checking, that because bicarbonate and potassium have a balanced relationship, if the bicarbonate is low, it could be pushing the potassium up. So for example, last week we had a baby with a bicarbonate of 8, which is very low, and the potassium was high. When the bicarbonate was corrected, the potassium came down to normal ranges. It seems obvious, but always checking if it's a hemolyzed sample, because the most amount of potassium is stored within the blood cells, and if the blood cells burst and release their potassium, this will give a falsely high potassium level. So always checking, and the labs should be putting that as a note if it's a hemolyzed sample. And also, which we will discuss in the next few slides, is doing our dietetic assessment and checking whether the child is catabolic. So is there a lot of breakdown, and is there lots of potassium being released? Is this a cause of potassium being high? One of the other things to remember, which has come about occasionally in the last few years. If a child is chronically constipated, because we lose about 10% of our potassium from our faeces, this could be a cause of high potassium, so it is absolutely worth bearing that in mind. I suppose the exceptions to mention would be for our tubulopathies, so our children with, say, Barter's or cystinosis, who would be on medicines to increase the amount of potassium and phosphate they're given because they lose high amounts in their urine. But so normally we'd be looking to change the medicines first. If the kidney function was declining, we'd be looking to decrease the amount of potassium and phosphate given to the kidney from the medicines first before we look at changing the formula. So when we look at the where we would potentially use a low potassium feed, it's easier when the child is less than 6 months old and they're already on formula milk, so they're used to drinking a formula milk, and we can adapt that. When the child is over 6 months old, they're still on a formula milk and oral diet, but the formula milk again can be changed. It's worth noting that for children that are over 1 year old, there are alternative low electrolyte products that could be used, which would, like juice-based supplements or milk alternatives that could be used from a palatability point of view if the child was orally feeding and we were trying to avoid tube feeds. For children that are over 1 year old and they're already on formula or they're tube fed, changing to a low potassium formula is much easier. The overall aim for these scenarios is to decrease the amount of potassium given to the body, and it's worth noting that decreasing the potassium in the feed could allow less restrictions to the oral diet, which is very important as appetite could be affected by many other factors. So when I'm looking at changing to using a low potassium feed, the things that I want to ask myself are, as any dietitian, is what are our nutritional requirements? What are we aiming for? And looking at energy, protein, potassium, phosphate, and fluid. So all these elements are important to remember. As all dietitians, we want to assess what their current nutritional intake is like. So what are they managing to take on board? What are they managing to, are they fully tube fed? Are they fully formula fed? Are they eating? Is the child growing? And we talked about the trend, it's making sure that they are growing and following their centiles. So that is extremely important, the same as any other child that we would be monitoring their growth. And if I make this change, what difference does it make to the nutritional breakdown? So we'll get into that when we do the case study. So we want to know what the difference would be. Essentially, how much fluid are we allowed is a very important question, and why it's very important that we discuss with the team the changes that are being made to the feed, to the dietary intake, and we can put that into the clinical picture, fit it in so that we are trying to only change one thing at a time and everybody is aware of what the changes are being made. We will come on to this later, but also, are we using scoops or are we using scales for the recipe? Because that will influence how we make the feed up and how we work it out. So when I'm looking at the next steps, once we've had a look at our other factors, so our medicines, our clinical picture, our biochemistry, what is happening in the big picture, we're needing then to decide what is our next step of how to introduce this low electrolyte feed. And we would then be looking at kind of deciding our ratios, how much we'd be using, because ultimately our basic aim is to put less potassium into the body, as we know that it's not coping with the amount of potassium that it is currently getting. So mainly as an inpatient with an acute kidney injury, they would be the ones that would need 100% low potassium formula if they're hyperkalemic or anuric, and we know that their potassium is already high or that will continue to increase rapidly if we don't manage to decrease the amount of potassium that we're giving to the body. We want to ask ourselves for other clinical pictures. Is the potassium quickly rising or is it slow rising? What is the trend? What is it? How fast is this happening and how fast do we need to react to it? And we've got lots of options. We can either use a quarter, a third, half as a low potassium feed based on what they're currently having. And worth bearing in mind that if they're growing well, we keep the energy content the same. So it's wanting to kind of keep only change one thing at a time and they're growing well, so we don't need to change the energy content. But if they're not growing well, we can consider increasing the energy by increasing the volume of feed or the concentration of feed, and always communicating with the medical team to find out how much volume we're allowed. I think it's important to consider urea in this discussion because of its relationship with protein and nutrition. And with declining function, urea will be increasing. And we find that from dietetic assessment, we will be assessing if the child is meeting the requirements, as catabolism can increase urea levels, as we've mentioned before, because the body is breaking down its own protein stores for energy and producing urea. And this excess protein will increase the urea levels, so we want to avoid the exacerbation of this with excess protein. And we would be looking at our protein requirements. So when looking at our changes to the feed, we would want to avoid the significant increases and comparing it to the protein requirements that we would be working out based on either local guidance, or last year, very handily, there was the Paediatric Renal Nutrition Task Force who released a guideline on energy and protein requirements in children with chronic kidney disease. So that can be a very good baseline to start from to get an idea of how much protein we'd be looking at for these children. When we are then looking at the other elements, we want to consider phosphate and calcium, because these two elements do come together. When we have a low potassium feed, it is lower in phosphate and calcium compared to standard formulas. And normally as potassium levels rise, so kidney function is not coping as well, so do our phosphate levels. And this is mainly towards the end stages of chronic kidney disease and also in acute kidney injury. As chronic kidney disease progresses or acute kidney injury occurs, we may be looking that it may be that phosphate binders have been started to manage a high phosphate level, and phosphate binders may be a source of calcium but also may not be a source of calcium, so it's worth checking this out. And we'd be wanting to do our dietetic assessment to check that they're still meeting their calcium requirements, whether that be through diet or through the phosphate binders, and partly through the feed as well. Again, luckily, the Paediatric Renal Nutrition Task Force released a guideline on the calcium and phosphate management in chronic kidney disease, and the link is in my references. So the other considerations to bear in mind when we're looking at kidney disease is that lower potassium feeds are higher in sodium as well. And this is important to communicate the changes with the team, especially if they're on sodium supplements. We want to inform the team how much sodium they're getting in their feed, especially if there is going to be a significant change. We also want to monitor the changes in magnesium in their feed due to the accumulation of magnesium in chronic kidney disease. And so that is something worth bearing in mind and monitoring as part of their biochemistry. Micronutrients are normally okay because the feeds are designed for complete nutrition, but we need to remember and take into account if the child's are they on full feeds, are they not on full feeds and eating as part of meeting their nutritional requirements, and also if they're on dialysis, they may be losing some of their micronutrients. So there is no vitamin and mineral supplement designed for children with kidney disease, unfortunately. So it may be that if we're looking for vitamin and mineral supplements that are required, we'd be also bearing in mind that we're not wanting to add in additional potassium, additional phosphate, and also worth remembering that we want to avoid over 200% of the recommended nutritional intake of vitamin A. So we want to avoid over 200% of our requirement of vitamin A, because vitamin A accumulates in chronic kidney disease and causes calcification of vessels. Low potassium feeds are also lower in vitamin A, so this does help, but it's worth bearing that in mind when you are looking at the full picture. When we look at practically introducing a low potassium feed, so what practical application this has, I think it's important to remember how our standard infant formulas are made up. So at the start, we're deciding whether we're using scoops or scales. And I think for me, scales are always more accurate. And this is the way I practice, but it may be different and we may have different options depending on the availability of scales, digital scales, or depending on the resources that are available. So that is our first thing to decide whether we're using scoop or scales at the start. Because if we were to take all of us and ask us all to measure out with a scoop 1 scoop of a formula, we would all have a slightly different result. So this is why I would use scales, but scoops may be more practical in lots of instances. So when we're looking at standard infant formula, in 600 ml a day at a 13% concentration, so what this means is there's 13 grams of powder in 100 ml. So in 600 ml of formula at a 13% standard formula concentration, there would be 78 grams of powder in 600 ml. So that is just always remembering that then helps you to then work out the next part. Now I tend to write my feed recipes using the ingredients separately. So for the example below, with half a standard formula at 13% and half a low potassium formula at 13%, for 600 ml a day, I would look at it separately and say for a 13% concentration of 300 ml of standard formula, I need 39 grams of powder. And for 13% of a low potassium formula in 300 ml, I need 39 grams of powder. And that's the way I would work it out. So you've got the two different powders at 39 grams, and then you would top it up with water to 600 ml. There is different ways to write that, and you could potentially write it as 6.5% standard formula, 6.5% low potassium formula, depending on the way you would normally work. It's worth noting that when you're using scoops, their scoop weights can vary amongst brands, and for the purposes of this talk, I've picked a standard formula with a scoop of 4.6 grams, and for a low potassium formula, a scoop weighing 7 grams. But these will vary, so always read the data card, read the label. For our standard formula, you'll notice that if we're using scoops, there are slight differences in the amounts above compared to the last slide, but what you have and what you're making the changes, you're using the same equipment, so it's always making the changes depending on what you've started off doing. So for example, round up, if you like, to get 3 scoops in 100 ml to make roughly a 13% concentration. This is 13.8% concentration for 3 scoops in 100 ml. Because if we were to try and do half a scoop, a quarter of a scoop, 3/4 of a scoop, there's more room for inaccuracy. So when we're making up 600 ml of the standard infant formula, we're then looking at 18 scoops in 600 ml. The other, when we're looking at using the low potassium formula, and again, I've written this out as considering the ingredients separately, for 300 ml of 13.8% standard formula, we're looking at 9 scoops. And for 300 ml of a 14% low potassium formula, we're looking at 6 scoops. And this is because we've had to round up with the numbers that we have. Layla, one of my colleagues, did a talk that's on the VIA website on this, so it's worth checking that out for further practical application. So when we're looking at how this compares, we can see that per 100 ml of each formula, the calories are roughly the same. With the standard formula and the low potassium formula, you see that the protein is slightly lower, carbohydrate slightly higher. As we've been discussing, the potassium, the phosphate and the calcium are lower, but the sodium is higher. So it's worth bearing this in mind. And when we, as I was saying before, as a tip to always write it out per 100 ml so that you can either increase the volume or decrease the volume depending on what is happening, then I would write it out per 100 ml for your energy, protein, carbohydrate, potassium, phosphate, calcium and sodium, okay? So this brings us on to our case study, and hopefully this will lead us to applying this knowledge in a very practical sense. And I've picked a child that I had last year who was a term baby boy. He was born on just above the 50th centile, and this is using the World Health Organization growth charts. We found that he had an acute kidney injury due to his hydronephrosis and his posterior urethral valves that the surgeons resected at day 11, so they managed to correct this part of this plumbing problem. We noted that he is polyuric, so this does have an influence on how much fluid we need to give this child, and trying to meet his fluid requirements so that he doesn't become dry. When we look at our biochemistry, I need to highlight that we all use our own hospital reference ranges and they will differ, so do bear that in mind. And we're always looking at the pattern of the biochemistry rather than just a snapshot, Okay, so we're always trying to look at the trend. So we've seen that his sodium is normal range, the kind of upper end of normal range. His bicarbonate is low, potassium is normal range, urea is high but is stable, so we know that from the trend, and his creatinine is high but stable, and we know that again from the trend. When we look at his growth, we can see that on day 19 he's dropped 1 centile in birth weight. We now have a height, which is very important to monitor from the start, because height is an excellent indicator whether we're getting enough nutrition for a child to grow, as well as head circumference, because of the changes and the fluctuations in weight that can be present because of the fluid changes that we're making. The energy requirements that I've used here are based on the energy and protein requirements from the task force that I was discussing earlier. And you can see that with the current feeds that this child's receiving, on 150 mils per kilogram, which would be the normal fluid requirement for a child this age, we're achieving the calories and the protein on paper for their requirements. But you can see that from their fluid requirements, they're polyuric, so we're needing 185 mils per kilogram to maintain homeostasis. So our plan is to then give this child a bit more support, because they're not managing the amount that we need them to take orally, with oral feeds with NG top up using the standard formula, because the potassium is still in the normal range and the creatinine and the urea have been quite stable. And we're moving to 3-hourly feeds to give that 185 mils per kilogram. Again, you can see that we've increased the calories and the protein within the requirements that we have there. And it's worth noting that the child, we are giving more than the requirements on paper, but remember that they've lost a centile in weight, so the extra calories will hopefully encourage that child to start gaining weight and following and tracking a centile. So our aim for this child at the moment is to promote growth and to remain hydrated because of their polyuria. And we're changing one thing at a time, so we're bearing this in mind. We've changed one thing to increase the volume of the feed, not change the feed, and we're going to measure the amount of protein and keep an eye on the bloods. Because we've increased the amount of protein, we'll keep an eye on the urea. So when we look at this child again on day 23, then what we're finding is that their weight is tracking, so they're following above the 25th centile. Unfortunately, their acute kidney injury is worsening, and we can see that their hydronephrosis is increasing in size. And the surgeons and the medical team have found that there is posterior urethral narrowing causing this blockage, if you like, causing this back up into the kidney, which is worsening the acute kidney injury. We can see that we always take their medications into account, and oxybutynin isn't something that would be influencing any decisions that we would be making. When we look at their biochemistry, it's worth remembering that always use your own reference ranges, but remember that a baby will have higher potassium tolerance than an older child. They're a bit more elastic, so they do have higher normal ranges for potassium, so do bear this in mind. We can see that their bicarbonate is low, but it's not low enough to be the sole cause of this high potassium, and we can see that the urea and the creatinine are rising and the creatinine is increasing. So we can see that the kidney basically is not coping with the current amount of potassium that we're giving it, so we need to lower it. That is our aim. And there's more than one answer of how to do this. We could go for 100% low potassium feed if that is what if that's what the medical team feel. If we're not managing to improve this posterior urethral narrowing quickly, for this child to prevent further increase in potassium, we've gone for half the standard formula and half a low potassium formula. So then, when we look at the difference in these feeds, we can see that for the volume that they will be receiving at the 185 mils per kilogram, we have lowered the amount of potassium, phosphate, calcium, but we've also increased the amount of sodium. So worth bearing that in mind. But it's meeting our aim. We're keeping the calories very similar, the protein very similar, but we have decreased the amount of potassium that we're giving to this child. Just to mention, actually, is that you'll see the calcium in the new feed of the half standard formula, half low potassium formula has decreased, but this is a short-term change because it is an acute kidney injury, hopefully with a reversible cause. So not meeting your calcium requirement in the short term is not going to cause us long-term problems. but something to bear in mind. So when we then look at this child on week 7, we can see that a lot of the problems have been resolved. Their posterior urethral valves have been resected, and that was on day 11. Our posterior urethral junction narrowing has been resolved with surgery, and we can see that our acute kidney injury is starting to resolve as well. We know that their medications are giving them a source of bicarbonate now, which has pushed their bicarbonate into the normal range, because we can tell that the kidney is losing bicarbonate. They're on trimethoprim, which can either be used as a treatment dose or a prophylactic dose, but I believe the prophylaxis of trimethoprim is now falling out of favour. And they're also on lansoprazole, because we've identified, which is understandable, that with the volumes that we're asking this baby to take, they're refluxing. So when we look at the biochemistry, we can see that there is still a degree of kidney impairment. So we can see the sodium's normal range, bicarb's normal range, potassium's in normal range, but also decreasing. So that is our trend. Our urea's in the normal range and nice and stable. And our creatinine is 59, which is high, but that is also decreasing. So things are improving for this child. We look at our growth and we can see that our weight is tracking well, just below the 25th centile, which is where they have been, apart from the first one at birth, it's where they have been for the last 6 weeks or so. And their height is also tracking, which is a great indicator, because if we achieve optimal growth and nutrition in the first 2 years of life, then we're achieving optimal growth of the kidneys and optimal recovery and function of the kidneys, which will improve their future outcomes. So when we then look at our feed decisions, what we do now, the kidney function is improving, the potassium's in the normal range and is decreasing. We then would be looking to the initial aim is achieved to improve the potassium levels and keep them in the normal range. And our oral intake is improving, although they are refluxing. So one of the things to note with this child is that we did avoid oral aversion with an NG tube, because it decreased the pressure to meet the high fluid requirements due to the polyuria. So we weren't trying to ask this child to take orally 185 mils per kilogram, which is a big ask, especially with surgeries and impaired kidney function. So that did help. So our options here, and there's no right or wrong way to do this, our options are to change to a standard formula now, or to change to 1/4 of a low potassium feed before then changing to a standard formula. And the aim overall is to increase the potassium from the feed as the kidney function is improving, and then we would assess this change. As we said, we're always adjusting and monitoring. So when we look at comparing options, and it's worth writing this out, so we've got our comparisons. For the volume that they're having, we can see what we would be achieving with, what we are achieving with the half standard formula, half low potassium formula. If we look at using 1/4 low potassium formula and 3/4 standard formula, we can see that we've increased the potassium, but if we were to move to full standard formula, we'll increase the potassium even further. If you are unsure of the decisions that are needing to be made, if you're unsure of the which option to choose, I would always say that I would always ask you to speak to the medical team and ask them which step they would prefer if you're not sure of the right choice to make. And as I said, there's no right or wrong. Our aim is overall to increase the amount of potassium that the child is getting, because we know that they're coping much, much better and the kidney function is improving. So in conclusion for this case study, we have seen that with the acute impairment of the kidney function that's caused the hyperkalemia, so the plumbing problem that was there before has been resolved from the surgery, from the urethral valves resection and the narrowing. The kidney function has been improving after surgery, and we've avoided medical intervention for hyperkalemia, as it is avoidable with a low potassium feed. So that is something to bear in mind. We've avoided any further medical intervention with a low potassium feed, and we've managed to maintain growth and meet their energy requirements to improve future outcomes. The other factors that came up from this case study is that the child was polyuric and needed nasogastric support to meet their fluid requirements, and the child has also been refluxing because of the large fluid requirements, and thickener is also an option with feeds. It was tried with this child, but they stopped drinking it as much orally, so we stopped the thickener, and the vomits weren't causing us enough of a problem not to meet our fluid requirements, so we didn't continue with the thickener. So our nutritional aims for this child were to meet the fluid requirements, promote growth, maintain potassium within the normal range, and we've met these requirements, we've met these aims. And always remember that prevention is better than cure. We don't want to get into this stage where the doctors are having to get involved to correct a potassium level with, say, salbutamol or insulin, or further steps which we can avoid. So essentially, we are changing the amount of potassium given to the kidneys if they show that they're struggling, to prevent medical intervention to treat hyperkalemia. Just a wee note on rules for concentrating the feeds, and this will be something that is brought out in the Paediatric Renal Nutrition Task Force when they release a practical guide, which will be coming soon, a practical guide for applying energy and protein requirements. When we're looking at a standard formula, which is normally about 13% concentration, as we said, 100 mils has 13 grams of formula in it, which gives us about 67 calories. If we are concentrating feeds, we would always do it gradually, one thing at a time. The reasons that we might need to concentrate a feed would be for a limited volume that's allowed, so the kidney's not managing the fluid balance well, and we're not able to have the full fluid that we need. Or they may be extremely refluxy, have problems with vomiting, and we don't want to increase the volume from that point of view. So when we increase one thing at a time, we'd be looking at 1 gram increase in carbohydrate per 100 mils, or 1 to 3% increase of feed at a time, and seeing what that does to your recipe and your nutritional breakdown. The reason we take it slowly is because it increases the osmolality that may cause diarrhea, vomiting, and gastroesophageal reflux. And the vomiting and the gastroesophageal reflux can be common symptoms or common ailments of children with kidney injury or kidney disease. We also need to note that we would be increasing the renal solute load by concentrating a feed, increasing the phosphate, the potassium, magnesium, vitamin A, protein, energy, and increasing the other nutrients that we were talking about with the vitamin A and before. So what I hope that we have covered is when and how to use a low potassium feed and the practical application. The key considerations that I'm going to go over again when using a low potassium feed, and hopefully we've consolidated these points using a case study in a practical way. So just to remind you of the key considerations that we need to make is that if we make a change, we always then monitor it. What happened next? What difference did it make? Did we achieve our aim? We always look at the growth, the biochemistry, and the clinical picture so that we are managing all elements. And again, I need to highlight that if we are using a low potassium feed, the risk is the potassium becoming too low if the kidney function starts to improve, if it starts to change, and we can run into the same problems with hypokalemia, so a low potassium, as we would with hyperkalemia. So always worth monitoring if we do make this change and communicating that with the medical team so they know what has been changed and what the risks are. And again, I can't stress highly enough the tip that when you document a feed breakdown, do it per 100 mils per recipe so that you know if you need to go back to a previous recipe if kidney function is improving, or you need to go a step further. You've already done the maths, which does take a bit of time, but you've already then worked out per 100 mils what it would be so that you can increase the volume or decrease the volume if needed. So these are a few references just as pointers of relevant guidelines that have been released just last year, and also our clinical paediatric dietetics textbook, which is an excellent source of information. So I will be happy to take any questions.
Brilliant. Thank you, Fiona, and thank you for taking us through that topic in such a clear and concise way. We do have a few questions that have come through, so I will fire these over to you. So the first one is with regards to the point about monitoring. So we've had a question which asks that when you're introducing a low potassium feed for the first time, how soon would you have a patient's bloods checked?
So it's a very good question, and I would say that it's a decision that's made as a multidisciplinary team. So you're making that decision with the medical staff knowing what the change has been, how significant the change has been. So I suppose it depends on how urgent you need to see the change. Often with this joint decision with the medical team, we give them the information and explain what the difference has been, and we're putting together how well the kidney's functioning. And I would say that in our urgent cases, if they're hyperkalemic, they're often checked the next day. But if they're hyperkalemic with symptoms of, say, cardiac arrhythmias, they're often, or they're needing further medical management, they're often checked multiple times that day until the potassium moves into the normal range. If it's an outpatient that you're changing the potassium and it's more of a chronic decline in kidney function, it may be the following week, it may be we bring them back later on that week to see if there has been a change in the biochemistry. If they're a child that's eating, we maybe leave it a bit longer, but it'd be definitely worth communicating that with the team, because it's often a joint decision with the doctors to look at when we then follow this up.
Brilliant, thank you. And we've had another question through, which is with regards to vitamin C. So the question is vitamin C something that you would look at with these patients, and is it something that you would monitor in terms of the blood lab results?
It's a very good question. For our dialysis population, we often do, if we are concerned about their nutrition, we do a nutritional assessment of their blood, so looking at their different levels. Vitamin C isn't something that I tend to look at or worry about too much. The main nutrients that I would focus on, as we discussed in the talk, would be the potassium, phosphate, magnesium, vitamin A, and I suppose vitamin C, because it's a water-soluble vitamin, and because the feeds are quite well balanced and fortified, it's not something that I tend to worry about. It's not something that I practically do look at, to answer your question. I think there's bigger elements to this, bigger important nutrients.
Great, thank you. And the next question is with regards to when you're using a low potassium feed alongside like a standard formula. So the question is, would you always start them off at the same concentration, or would you sometimes have the low potassium formula at a higher concentration than the standard formula, if that makes sense?
So the answer to that question is that we don't always change the same. So in the case study that I gave you, we kept the concentrations the same, and this child was polyuric, so we didn't have to worry too much about volume. If we are restricted in volume and we need to concentrate the feeds, I would tend to try and do one thing at a time. So if we're moving to a low potassium feed, I would look at per 100 mils what the carbohydrate is giving us from their current formula. And then if we were needing to concentrate the feed, I would make the change to meet their, to decrease the potassium, which is the aim of using the low potassium feed in the first place. But then I would look at increasing the carbohydrate by 1 gram per 100 mils as a starting point. And then once we've done that and we see that they've tolerated it, we can then look at concentrating the feed further. So I suppose to answer the question, I would do one thing at a time, one thing being one concentration at a time. So if we know that they're standard concentration, we know the concentration, of the feed that they're getting, the carbohydrate per 100 mils that they're getting. And then when I do change to add in low potassium feed, I would potentially go up 1 gram of carbohydrate per 100 mils if I was wanting to start that journey to start concentrating the feeds. And things can be done. I know other areas would maybe do 1 to 3% increase in the concentration at a time if the child was tolerating the feeds well beforehand. So these are the kind of two constant. I would make that change to concentrate the feeds if we needed to. It doesn't always have to be the same concentration, and it's trying to make it fit to best meet the child's nutritional requirements and our nutritional aims, what we're looking for. I hope that's answered your question.
Brilliant. It actually leads quite nicely on to the following question, which is with regards to concentration of feeds as well. So how high would you concentrate a low potassium feed?
So there are textbook guidelines. So there are textbook guidelines in our clinical paediatric dietetic textbook of looking at the maximum tolerance for macronutrients. So for example, for this child that was under 6 months old, we'd be looking at 10 to 12% carbohydrate, 5 to 6% fat, which is about a 0.7 to 1 cal per mil formula. And then as they get older, looking at a 1 to 1.5 calorie per mil formula from 6 to 12 months, so that's 12 to 15% carbohydrate. What I will say is that renal can sometimes be quite bespoke, and I would be guided more by how the child is coping with the feed increases, and also how much fluid we're allowed, because we're often pushed into if the child is anuric or they are really struggling, we're really struggling with the fluid volumes and we're not able to get much in. It can be that we are concentrating more at each step, but I would only do one step at a time and assess their tolerance. So to answer your question, we have got textbook guidelines as the maximum tolerance of the macronutrients, but it can vary depending on the child's clinical picture. So I hope that answers your question.
Great. And then a further question is with regards to, you mentioned about the use of a low potassium feed could potentially help with making the oral intake a bit more free or a bit more liberal. I'm just wondering if you could expand on that a little bit more.
Absolutely. So if a child, I would always rather change a formula feed than restrict a child's oral diet if possible. I think our first step is always to try and decrease the potassium from a very easy way to do it that won't affect the child's appetite or restrictions on their diet. Because as we know, with chronic kidney disease, with acute kidney injuries and the associated symptoms that come with that, the children can often have quite a poor appetite. And if we need to look at restrictions further down the line, if it's chronic kidney disease and we're needing to look at more potassium restrictions, phosphate restrictions, then I would always rather change the formula feed first to allow them more flexibility. So this could be, for example, if we're talking about babies, when a baby is weaning, we know that babies don't take very much. Practically, a lot of it ends up on the floor. They don't take very much from a oral diet when they start weaning, and as they start to build up their meals, if we can allow them the kind of normal weaning stage and normal variety in their diet, then this will help to with their food acceptance, with parental anxiety about what to give them, what not to give them. We want to try and avoid that for as long as we can, and using a low potassium feed can be really beneficial, so that with a child who's weaning, say from 6 to 12 months, we can change the formula feed to allow them a greater variety and flexibility with their diet, which will also make it much easier for parents to wean their child.
Brilliant, thank you. And our very last question is just with regards to resources, really. So what would you say are your go-to resources for any dietitians or doctors who are looking into the dietary management of children with kidney disease?
So the guidelines that were released last year from the task force have been extremely helpful, because it is consolidated. Beforehand there was Kudoki, and we used that it was a big read, but we used that to base a lot of our practices on. And the most recent guidelines from the task force have hopefully consolidated the Kudoki evidence and also any new evidence that has come up and brought it together. So I suppose that is a very good starting point. All areas will probably have their own resources, like we have our renal nutrition handbook, we have our competencies. In terms of using resources, each area or each hospital does have their own low potassium resources, low phosphate resources, or both, and we're trying to bring them all together. And I know the task force is also trying to bring them all together to make it much more universally available. So I suppose, I hope that's answered your question, but we use the most recent information, the most recent guidelines that are out there, which luckily were released last year for our energy and our protein, our calcium and our phosphate. Those would be the go-to, bearing in mind the information, that the practices that we currently use from a practical standpoint. And I know the practical guides from the task force will be coming out soon as well.
Brilliant, thank you, Fiona. So, and that brings us to the end of our question and answer session. So, once again, I'd just like to thank you, Fiona, for presenting today, for such a clear and concise and really informative presentation there. So this concludes today's webinar, and on behalf of VitaFlow, we would like to thank everybody for tuning in today. Please take the time to complete the evaluation questions just before you leave the session, because we really do take that on board in terms of how we can best suit your needs really with regards to these webinars. Please note that our next webinar will be by the Paediatric Renal Nutrition Task Force and will be held on the 23rd of February. So goodbye everybody, and please enjoy the rest of your day.